This conference will now be recorded.
Good morning. I'm continuing with topic abdomen compartment syndrome. Primary abdomen compartment syndrome is almost commonly encountered in victims of multiple trauma, especially after damage control surgery as a result of ileus caused by bowel edema and contamination, continued bleeding, coagulopathy, packing used to control bleeding, capillary and lymphatic leak, massive fluid resuscitation and transfusion, closure of non-compliant abdominal wall under tension. In this 100% associated with abdomen compartment syndrome. Non-traumatic cause of primary abdomen compartment syndrome includes ascites, retroperitoneal hemorrhage, pancreatitis, pneumoperitoneum, after reduction of large ventral hernias, where abdominal wall lost its domain, long-standing huge ventral hernias, incisional hernias, abdomen is lax, content adhere to the surroundings, you may lose anatomy, rectus became weak. In that cases, he almost excised the lax part. So after excision, closure of the abdomen will become tough. For long-standing hernias, acclimatization of the abdomen contents in the abdomen is tough because the contents are present in the hernial sac, which are outside the abdomen. After repair of ruptured abdominal aortic aneurysm, complex abdominal procedures, liver transplantation, secondary abdomen compartment syndrome, commonly seen in patients with shock requiring aggressive fluid resuscitation with crystalloids, because after giving excessive crystalloids, bowel edema will develop, third space loss will occur. So chances of abdomen compartment syndrome are high. Paralytic ileus will develop. Thermally injured and shock trauma victims, critically ill hypothermic and septic patients, Those who have sustained cardiac arrest, diagnosis, use of the urinary bladder catheter has been gold standard and is the indirect method used to measure intra-abdominal pressure. Intra-abdominal pressure should be expressed in millimeter of mercury. Measured at end expression. In the complete supine position. After ensuring that abdominal muscle contractions are absent, with the transducer zeroed at the level of mid-axillary line, the reference standard for intermittent intra-abdominal pressure measurements is via the bladder with a maximal installation volume of 25 ml of NS. Intra-abdominal pressure measured in the following ways: using a regular Foley's catheter, disconnect from the urine bag, inject 25 ml, and then clamp, insert a needle and measure the pressure, or a three-way cannula, three-way Foley's catheter with saline injected into the one port and intra-abdominal pressure measured through the another. Regular Foley's catheter is serially connected to a three-way stopcock and a transducer. Abdominal perfusion pressure is equal to mean arterial pressure minus intra-abdominal pressure. Abdominal perfusion pressure reflects actual gut perfusion which is better than intra-abdominal pressure alone. Optimizing abdominal perfusion pressure to more than 60 mm Hg should probably be the primary endpoint. prevention of abdomen compartment syndrome, patients at risk of intra-abdominal hypertension and abdominal compartment syndrome are identified. Organ function is monitored and assessed, like for kidney, check for urine output and blood urea, serum creatinine. Lungs, hypercapnia, hypoxia, difficult ventilation, elevated pulmonary artery pressure, drop in PaO2 by FiO2, decreased lung compliance, intrapulmonary shunt, increased dead space, heart, decreased cardiac output and cardiac index, need for vasopressors, like adrenaline, noradrenaline, and vasopressin. For kidneys, oliguria, which is unresponsive to fluid therapy. Urine output is reduced. We will give fluid challenge. 250 ml bolus and then check for urine output. If it is improved, patient in dehydrated state. If it is unresponsive, after 1 hour, we may go for another fluid challenge. Still unresponsive, check for any third space loss and abdominal compartment syndrome and kidney function. Central nervous system, GCS score less than 10, or neurologic deterioration in the absence of head injury, neurotrauma, Patient become drowsy, non-responsive sometimes. Abdomen, abdomen was distended because of ileus and bowel edema. CT scan to check for fluid collections. Narrowing of inferior vena cava. Compression of kidneys. And rounding of abdomen. Intra-abdominal pressure measured and monitored with Foley's catheter or gastric catheter. Other tests to check organ dysfunction. Gastric mucosal pH. Near infrared spectroscopy to measure muscle and gastric tissue oxygenation. Abdominal perfusion pressure is mean arterial pressure minus intra-abdominal pressure. Renal filtration gradient. Mean arterial pressure minus 2 into intra-abdominal pressure. CT scan. Measures to reduce intra-abdominal hypertension. Drainage of intra-abdominal fluid collections. Muscle relaxation. Avoid primary closure of abdominal incisions. Laparotomy or mesh. Bogota bag closure. Biological mesh. or vacuum assisted closure. Management of intra-abdominal pressure. Patient has intra-abdominal hypertension, intra-abdominal pressure more than 12 mmHg. Initiate treatment to reduce intra-abdominal pressure by reducing excessive fluid resuscitation and optimizing organ perfusion pressure. If intra-abdominal pressure more than 20 mmHg associated with organ dysfunction, it is called abdominal compartment syndrome. If not associated with, then go for serial monitoring of intra-abdominal pressure at least every 4th hourly, and measures to reduce intra-abdominal pressure like reduction in excessive fluid resuscitation, improving organ function, then IAB comes to less than 12. For abdominal compartment syndrome, identify the underlying cause for abdominal compartment syndrome. Does the patient have primary ACS or secondary ACS or recurrent ACS? Go for abdominal decompression. Whatever the abdominal compartment syndrome, it is primary, secondary or recurrent. Initially go for decompression. Temporary closure. Continue medical treatment to reduce intra-abdominal pressure. Measurement of intra-abdominal pressure for at least every 4th hourly. Perform balanced resuscitation. Of patient preload, contractility, and afterload using crystalloid, colloid, or vasoactive medications. Avoid excessive fluid resuscitation. Improve abdominal wall compliance. by sedation, analgesia, neuromuscular blockade by muscle relaxants, avoid head of the bed more than 30 degrees, evacuate intraluminal contents by nasogastric decompression, Rayleigh tube, rectal decompression, gastro or colon prokinetic agents like metoclopramide, evacuate abdominal fluid collections by high volume paracentesis, percutaneous drainage, correct positive fluid balance by avoid excessive fluid resuscitation, diuretics, colloids or hypertonic fluids, if necessary go for hemodialysis, ultrafiltration, decompressive laparotomy, grade 4 intra-abdominal hypertension is more than 20, 25. Grade 3 intra-abdominal hypertension with tense abdomen and signs of ventilation dysfunction, oliguria, severe head injury with intra-abdominal pressure more than 20 mm Hg, even without overt abdomen compartment syndrome, intractable intracranial hypertension without obvious head injury, surgical decompression can be achieved by opening the abdominal wall and abdominal fascia anterior in order to prevent compartment syndrome and create more space. Decompression leads to reduction of intra-abdominal hypertension, severe hypotension as a result of sudden decrease in systemic vascular resistance, and abrupt increase in the class చెప్తున్నా చెప్పు అక్కడి నుంచి వచ్చినా అవును abrupt increase in the true tidal volume delivered to the patient with washout of byproducts of anaerobic metabolism from below the diaphragm. This results in respiratory alkalosis, decrease in effective preload, and a bolus of acid, potassium, and other byproducts delivered to the heart where they cause arrhythmia or asystolic arrest, open abdomen management, చెప్పండి వాష్రూమ్ ద్వారా రెగ్యులేటర్ తప్ప రెగ్యులేటర్లో ఇచ్చింది వాష్రూమ్ ద్వారా వెళ్తున్నావు ఎప్పుడు వెళ్తున్నావా an open abdomen requiring a temporary abdominal closure due to skin and fascia not being closed after laparotomy, once opened the fascia can bridge for support and to prevent loss of domain by variety of medical devices, Bogota bag, artificial burp, vacuum device, vacuum isolated closure, increases blood flow, increase granulation tissue, decrease bacterial count, decrease tissue edema, This is tension band suturing. For each suture material, there is rubber or plastic tubes to prevent burst of abdomen and to maintain the contour of abdomen. This is Bogota bag. Generally we use urinary bag. Bogota bag contains the evisceration of the abdominal contents in the treatment or to prevent intra-abdominal hypertension. Which is cheap, immediately available, and easy to apply. Does not allow the effective removal of any infected toxin or cytokine rich intraperitoneal fluid. Does not prevent the retraction of abdominal wall. Conclusion: identification of patient at risk, early recognition, prevention, and appropriately staged and timed intervention is the key to effective management of this condition. Thank you. Put your attendance in the chat box.